and the organising committee for the invitation to speak today. It's an interesting time to be talking about therapeutic hypothermia, given that the THAPCA study, which I'll come back to during the talk, which is a moderately large randomised controlled trial of cooling after cardiac arrest in children, will be the only study, randomised controlled trial that there is in this area, is I think presenting in about 3 weeks' time. So this whole area will be further informed, hopefully in a few weeks. Those of you, we had a day yesterday recognising the contributions of Frank Shan to paediatric intensive care and in fact to global world health. And one of the debates yesterday was around the role of clinical research, and Warwick Butt made the comment that hypothermia had only really consistently been shown to work in New Zealand mice. And I do need to correct something about that. In fact, this is the animal lab. A lot of the pivotal work in terms of neonatal neuroprotection from hypothermia was done at the University of Auckland by Professor Alistair Gunn and his team, but it was done in fetal lambs or newborn lambs, and this is from their research lab. Hypothermia should be, Pat talked this morning about a lot of the mechanisms by which brain injury occurs. Hypothermia should be the ideal neuroprotective agent in that it works on all facets of secondary injury. It reduces all of the things listed on the slide: energy failure, excitotoxicity, mitochondrial injury, oxidative stress, apoptosis and inflammation. And we understand something of the physiology of it, and this again comes from Alistair Gunn's work. We know the optimal duration and therapeutic window, the temperature at which it appears to work best is between around 32 to 33 degrees. There's a very narrow therapeutic window of probably about 4 hours, and the optimal duration appears to be at least, requires a minimum of 48 hours. And this is from the fetal sheep studies, just looking at the ideal temperature, and in particular the effect of delay in implementing hypothermia on protection. So the control bar there shows you the almost 100% neuronal loss. You can see if hypothermia is implemented within an hour and a half, you get very good protection, but the more it's delayed, the less protection you get. This work that Alistair Gunn did, he presented, in fact, I was reflecting on this, I was putting this talk together, but he presented it to the ANZICS meeting in Christchurch in 1999. I appreciate that many in the audience may have been at school at that stage, but in 1999 he presented, I was sitting with Frank Shan, and everyone was sort of impressed with the data that was presented. Not long after that, the neonatal studies came out, along with the adult studies, and in this part of the world we were very early adopters of therapeutic hypothermia for both traumatic brain injury and post-cardiac arrest. And so it's interesting to reflect now 15 years later and ask everybody, I'd be interested to know that if, for example, you had an 8-year-old with severe TBI early after injury, say 2 hours after injury, who in the audience would call that patient now? Nobody? A 4-week-old baby with an out-of-hospital cardiac arrest? There's a few hands, not many. And a 14-year-old with an out-of-hospital cardiac arrest? Quite a few, okay. So before we just talk about, I would talk about hypothermia, I do want to talk about fever and acquired brain injury, because fever is very common. It occurs in almost half of children if you let temperature evolve naturally within the first 24 hours, in both children and in adults. And fever is bad, it is associated with the worst outcome in almost every form of acquired brain injury. And so this is just a cartoon which actually shows the benefits of hypothermia, but all of the mechanisms by which hypothermia protects the brain, hyperthermia or fever exacerbates secondary injury. And so fever is bad for the injured brain. It's an association, it's not a cause, although in animal models, if you actively cool to reduce fever, then you reduce the amount of damage that occurs. And in adults, fever is associated with both, adults, children and neonates, fever is associated with increased mortality and worse neurological outcome. And so in adults, for every degree above 37 degrees, the odds ratio of an unfavourable outcome is 2.3. Children, somewhat similar, 2.7. And in neonates, for every degree, the odds ratio above 37, the odds ratio is 3.6 to 4. So now getting back to therapeutic hypothermia, it is the most studied neuroprotective therapy so far. And so what I want to do is just quickly skirt through the evidence in traumatic brain injury, hypoxic ischemic injury after cardiac arrest, and then just briefly a couple of other acquired brain injuries. And I think for traumatic brain injury, the evidence is very clear now that there is no evidence for a beneficial effect of early hypothermia on outcome in TBI. All of the multi-centre randomised control trials in adults and children have been negative so far. And this could be for a number of reasons. It could be that the treatment wasn't started early enough, and the POLAR study that the ANZICS CTG group are doing will be looking at that. It could be that it wasn't continued long enough. It could be that we rewarmed too fast. There are lots of reasons that it might not have worked, or it may be that it just doesn't work. And so it would be fair to say that early hypothermia should not be used in TBI currently outside of a randomised controlled trial. There are, in this area, almost more meta-analyses now than there are studies. This is one of the more recent ones. It was a nice one actually that was published in the British Journal of Anaesthesia, which shows all of the studies. And if you put all the studies together, then there's an apparent benefit to hypothermia. But if you only look at the high quality multi-centre randomised controlled trials, then in fact there is no benefit and there's possible harm. And that's heavily influenced by the Canadian hypothermia study in children, which showed possible harm. And following on from this, we, as many in the audience know, did a pilot study looking towards doing a phase 3 trial, which was the HITBIC study, and you can see our outcomes here, which shows no effect, no benefit, no harm. I mean, it is only a pilot study, so it's not powered to try and find, but the two groups are almost identical in terms of their outcomes. On the basis of that, we joined the North American CoolKids study, which unfortunately shortly after we joined it was called off for futility. And you can see here the outcomes in the CoolKids trial, where there was, in fact, I mean, essentially there was no difference in terms of the poor outcome rate. They were identical. There was a slightly higher, which is one of the reasons that the study was called off. There was a slightly higher mortality rate in the hypothermia group, but there was a slightly higher rate of vegetative outcome in the normothermia group. So when you combine those together, in fact, the poor outcome rate was identical, 42% in both hypothermia and normothermia groups. In an editorial that went with this, there's a meta-analysis of the paediatric trials, which again show no benefit and possible harm. There are a few interesting lessons from the methodology of randomised controlled trials. This is from our pilot study. The time to randomisation was 5 hours, so it means our ability to be able to randomise early is very limited. And so the time to target temperature was, we actually managed to cool the kids pretty quickly, but it was nearly 10 hours before we actually got them to target temperature. And the other interesting thing, and I guess it fits in with what Pat was showing this morning about the good outcomes that we now see, I think, in many paediatric ICUs, the bad outcome rate was 14%. So that was death and severely disabled children. So the mortality rate was around 8 or 9%, and there were 5 or 6% who were severely damaged. But that raises a lot of problems about adequately powering studies to show a difference in terms of the bad outcome rate in children. And you can see this even in those, so the bad outcome, we actually had no, in this small study, we had no vegetative survivors, but that for the oranges, I am colourblind, I think it's orange, severely damaged children and 6 is dead. And so there are, even in those with a GCS of 3 to 4, the outcomes were surprisingly better than we expected. In terms of whether it's just that we didn't start, or cooling's not been started early enough, as I mentioned, the POLAR study is looking at that in Australia and New Zealand, but Guy Clifton's study, which also did the same thing, they enrolled patients within 2.5 hours, cooled for 48 hours, so longer than the previous adult studies, and showed no difference overall. In subgroup analysis, those that had surgically removed hematomas may have done better with therapeutic hypothermia, but the problem with subgroup analysis is that if there was no difference overall and the surgically and the hematoma group did better, then it means those with diffuse brain injury did worse. So if you look at those subgroups, then that's how it would be interpreted. I think the important thing is that it didn't show a difference overall. Almost all studies have shown that hypothermia reduces ICP. There are no outcome studies currently, although the Eurotherm trial is looking specifically at that. And so hypothermia does remain an option when other standard treatments of ICP are not working. So overall in traumatic brain injury, we can say that therapeutic hypothermia should not be used for neuroprotection outside of a randomised control trial. It may have a role for It may have a role in the management of ICP, however, later on. So now let's talk about hypoxic ischemic injury, and starting off with neonatal HIE. And this is where I think the literature does get very complicated, because the evidence in neonatal trials is pretty convincing. There are, and in fact, there are a few more trials, and different meta-analyses have included different numbers of studies, but there are at least 1,500 infants in 11 trials, and there's a high degree of consistency, both in terms of the injury that occurs in neonatal HIE and the trials that have been done, both for how they've all called for 48 to 72 hours, they've all used the same outcome assessment. And so you can see here that the death or disability rate at 12 or 18 months, the risk ratio, so to the left favours hypothermia, to the right of the line in the forest plot favours control, and you can see a significant benefit to hypothermia with a number needed to treat of 6, an absolute risk reduction of 0.16. And looking the other way, the chance of a normal survival, so risk ratio of 1.6. And when you look at the neonatal studies, the components of the outcome are all concordant. Whether you look at death, disability, cerebral palsy, blindness, deafness, the effect is similar for all of those things. There is a smaller effect with severe hypoxic ischemic injury. A few of the early, in particular the CoolKids study, which stratified according to the EEG into moderate or severe and found a benefit in the moderate group but not the severe. And so there were concerns about that. But again, in this meta-analysis, you can see that there is a benefit in those with severe HIE, but it's less than in those with moderate HIE. And that sort of makes intuitive sense, I guess. And there's some of the studies have used head cooling, some have used whole body cooling. Again, the effect is relatively similar between the two. Recently, the long-term follow-up of the Toby study has been published in the New England Journal, and so this was the English study, and now looking at these kids 6 to 7 years down the line. And again, you can see that all of the outcomes are significantly better in the hypothermia group, whether you look at an IQ more than 85, the cerebral palsy rates, they're all significantly better than the normothermia group. So I think we can say in neonates that cooling improves outcome after moderate to severe encephalopathy in newborn infants. And it is improved, but to a lesser extent if you have severe encephalopathy. Functional recovery is delayed by cooling, and you get similar results from all of the cooling methods that have been tried. And admittedly, he has a conflict of interest. Edwards is one of the authors of one of their trials, or primary investigators, but the remarkable homogeneity of the trial results, he believes, provides unequivocal evidence of the therapeutic benefit of prolonged hypothermia. What can we extrapolate from this? Well, I think it's very difficult because the mechanism of injury is somewhat difficult in neonatal HIE. It's often a more prolonged and probably lower grade insult. Many of the trials do not report the cardiac arrest rates, but in a couple that do, only about 2/3 of them have a cardiac arrest. And obviously in neonatal HIE, it's possible to start very early, much earlier than in any other injury that's encountered. And the other thing that's worth noting is that the normothermic group, between sort of 13 or 14% and 40% of the children had temperatures over 38. So the temperature control in the normothermia group is poor in many of the studies. And so you do wonder whether there would be a role for very tight normothermia versus hypothermia. Now looking at the adult studies, and you will all be aware of the sort of history behind this, that there were 2 studies published in the New England Journal in the same edition in 2002, an Australian one and a European one, both of which used somewhat unconventional methodology in some ways, both appearing to show a benefit to hypothermia in adults with community VF cardiac arrest. One called for 12 hours, one called for 24 hours, and on the basis of that, hypothermia became the standard of care for adults after community cardiac arrest. And on the basis of that and the neonatal trials, it became the standard of care in many paediatric ICUs. And the study that I guess has changed everything is the Scandanavian study, which again you will all be well aware of, the targeted temperature management after cardiac arrest trial, or TTM trial. Their cooling protocol was to cool over 4 hours, or cool as fast as possible, and then to maintain hypothermia for 24 hours at the goal temperature, either 36 or 33, and then 8 hours to rewarm. And then once they were rewarmed, sedation was weaned or stopped. Their temperature, and I think one of the things we all struggle with is how long should you maintain normothermia for? beyond the sort of the neuroprotection period, and their protocol was to maintain the temperature under 37.5 for 72 hours, at which stage they performed neurological assessment. Talking to some of the units involved, 36 degrees is still active therapy, and in fact, many of the bedside nurses found it more difficult to control the temperature at 36 than to control it at 33. Perhaps as a reflection of the cooling blankets and things that are used. This study was had superb methodology and performance. It's almost more than twice the size of both the original trials combined. They had a very tight protocol for withdrawal of life-sustaining therapies. And interestingly, the 50% good outcome rate, which is much higher than has been previously reported. But there was no difference between the two groups. And so the reactions of this have been interesting. Steve Bernard, who was one of the authors of the original trial, published in April in the British Medical Journal saying that this should change practice immediately. And Case Polderman, who's been another staunch advocate for hypothermia, in the same month published in Critical Care saying, urging colleagues not to abandon therapeutic hypothermia in favour of strict fever management on the basis of one study, and raised a few issues with the study. So what should we do in children? At the moment, ILCOR says it may be considered, hypothermia may be considered, so sitting on the fence for those who remain comatose after resuscitation. There are two moderately big cohort studies, because I think although in this part of the world we embraced hypothermia from pretty early on, that wasn't true in a lot of North America and Europe, and so in their cohort studies they were able to look at children in attempting to control for severity of injury with those that were cooled and not cooled, and have not found, both of those cohort studies did not show any difference in outcome with hypothermia and normothermia. We were part of a pilot study that was preceding THAPCA that was run by Jamie Hutchison that involved Toronto, Auckland and Great Ormond Street. And again, it was only a pilot study, but there was absolutely no difference in terms of the outcome between the two groups. And the THAPCA studies, there are two studies, an out-of-hospital group and an in-hospital group. I know the in-hospital group has had problems with recruitment and is still a long way for completing, but the out-of-hospital group has recruited on time, on target, and the results are all analysed and will be reported soon. And they cooled for 48 hours and did maintain very strict normothermia in the control group. So it should be somewhat like the Scandanavian group trial. So I would argue that hypothermia after cardiac arrest, the evidence does not currently support moderate hypothermia apart from in-birth asphyxia. Fever, as I mentioned at the beginning, is common and associated with worse outcome. There's a very good, large adult randomised controlled trial that suggests equivalent outcomes with a temperature of 36. And I guess the question is that mild, very mild hypothermia or controlled normothermia? And that comes down to what is a normal temperature, and that's been in the physiology literature documented as being between 35.5 and 37.5, although most clinical guidelines groups recommend or say that it's 36.5 to 37.5. There's a diurnal rhythm, it's lower in the morning, it varies with the site, it varies with the method of measurement. And so, as I say, definitions vary, and what we might call 36 degrees is that hypothermia or is that normothermia? Or is mild hypothermia just the only way that you can actually avoid a fever? And I think, one of the interesting things to look at is how well do we control temperature. And so the first study I have up here is one that was published in PCCM in 2010, which looked at the first 24 hours after in-hospital cardiac arrest in children. And 43% of the children had at least one temperature that was more than 38, and 5.5% it was persistently above 38, with an odds ratio of 2.7 of an unfavourable outcome. And they looked before and after the implementation of the 2005 guidelines, and temperature control was no different after the guidelines came in than before. And even in randomised controlled trials, most trials in the normothermia group set an upper limit of around 37.5, and the CoolKids study, 68% of the children were over 37.5 during the first 48 hours. And even in our study where we actually tried to keep it between 36 and 37, 40% of the time the temperature of 38 was exceeded at least once in the first 72 hours. So even in the setting of a randomised controlled trial where everyone is supposed to be obsessive about temperature, we don't do very well. And how much that's obsession with detail or the technical challenges of temperature control is difficult to answer, but we certainly don't do as well as we should. Just briefly to touch on two other forms of brain injury, stroke. There are phase 1 and phase 2 studies and have shown a benefit to hypothermia by many of the same mechanisms as in post-cardiac arrest and traumatic brain injury. And there are two large phase 2-3 studies underway in adults, both with sort of 1,500, 1,600 patients. But currently, anyway, it's not standard, certainly not standard of care, and should only be used as part of a randomised control trial. Hypothermia for meningitis. This is an adult study of meningitis published in JAMA last year of 98 adults. It was stopped early because of worse outcome in the patients that were called. So again, in meningitis currently, you'd have to say that hypothermia should not be used. And finally, just a word about predicting outcome if you're going to call patients. And this is a meta-analysis published this year in critical care medicine of studies looking at prognostication with the use of hypothermia. So it looks at 20 studies, but under 2,000 patients. And the three tests, all of the tests that were looked at were better after 72 hours from ROSC than before 72 hours. And the three tests that you would expect would be the most accurate, still are the most accurate: absent pupil reflexes at 24 hours, absent corneal reflexes at the same time, and bilaterally absent SEPs. And this just shows the data from that meta-analysis, and in particular, I mean, the pupillary reflex and SEPs, you can see beyond 72 hours had a false positive rate. I haven't, to keep the slide, I mean, the paper in fact includes the confidence intervals, and they will be go up to a couple of %, but you can see the false positive rate. So how often are these things wrong in predicting a bad outcome? So I was asked to also talk about hypothermia at the Paediatric ICU World Congress earlier in the year, and one of the questions is it gone for good? And I think the answer is no, but the outcomes are the same at the moment in terms of adult randomised controlled trials for mild hypothermia as opposed to moderate hypothermia. And so I would argue that moderate hypothermia may be gone for good, except in neonatal HIE. Certainly it should not be used as part of TBI management, and probably at the moment shouldn't be used after cardiac arrest currently, although we will know the results of the THAPCA study in a couple of weeks' time. And not in stroke and not in meningitis. And I do think that we do need to place a lot more emphasis on fever prevention. Fever is bad in acquired brain injuries, it's associated with a worse outcome, and we know that we don't do well in terms of controlling temperature in the first 48 to 72 hours. Thank you.